Welcome back to episode 19 of the Rehab Exercise and Sports Therapy podcast. I am really excited today to chop up some FAI and hip post-op rehab with Drs. Ashley Disantis and Keelan Enseki, who are both frequent authors and experts in this content area. If you do enjoy any of our content today, please be sure to like, repost, or subscribe to our feed that's available on Spotify and YouTube. Today, we're going to kind of delve into a paper that both of them were co-authors on, the 2024 International Society for Hip Preservation Agreement on post-op rehab for hip arthroscopy for FAI. I thought it was an excellent paper that really nicely broke down post-op hip arthroscopy rehab into different phases based on post-op interval, and really kind of emphasize and outline the kind of key rocks or foundational principles to make rehab successful after hip arthroscopy. So if you don't mind, Ashley, you were the lead author on the paper, so I'll let you go first if you don't mind introducing yourself, a little bit about your role and what you do right now.
Yeah, so my name's Ashley Disantis. I'm from Pittsburgh, born and raised, and I currently work at UPMC Children's Hospital of Pittsburgh, and I'm the orthopedic team lead for physical therapy. And I've been there for about 5 years now. Before that, I worked actually in outpatient with Keelan at the UPMC Center for Sports Medicine, and honestly started most of my hip stuff with him, actually all of my hip stuff with him. I was there for about 8 or 9 years before I made the jump to Children's. So currently my caseload is some FAI, but a lot of hip dysplasia is what I see currently. The surgeon I work with leans heavily into the open procedures. I also am involved in research. I'm getting my PhD, should be defending in 2 or 3 months at Duquesne.
Awesome.
And that's about it.
Right. Well, congrats on almost winding down the PhD. I know that's a long road, right?
Yeah.
Intensive road.
Yeah.
And Keelan, if you can give us a little bit of your background as well at UPMC.
Yeah, I'm Keelan Enseki. I'm like Ashley. I'm from I'm not from Pittsburgh, but I've been here over 25 years now, I think. So it is home. Went to the University of Pittsburgh for my physical therapy training, did a residency there, and basically never left the system with UPMC. Been at the Center for Sports Medicine, over 20-something years. It's hard to keep track. Been at least almost that whole time. My clinical focus has been working with individuals with hip-related issues, everything from non-arthritic, extra-articular to arthritic hip pain, and surgical procedures afterwards. Involved in our residency program, our run orthopedic residency program, had administrative roles in our others, and then a clinical innovation role within the UPMC Rehabilitation Institute.
Awesome. And I just have to ask now, since you are not originally a Pittsburgh native, right, and working at UPMC, have you adopted the Steelers, or do we still have other loyalties? Yeah, to
well, no,
team?
I'm pros is easy because I'm from central Pennsylvania, North Central,
okay.
So I'm a Penn State guy. It's more
Gotcha.
the football team, but I am a Penn State loyalist with football, so.
Fair enough, yes. Yeah. New coach, things are looking up, right, for Penn State?
I hope so. Then you could only get better after this year.
Yeah, exactly. Right. All right. So I thought that, again, the paper was great. I wanted to kind of go by phase if we could. What I was hoping, since I have both of you and you are both, extremely experienced and experts in this area, is maybe dabbling or delving a little more into some of the gray areas that, with my own personal questions and some of the stuff that maybe is not as clearly outlined in a lot of the protocols that are out there and that kind of thing. So for early post-op stage, I think we can kind of agree that there's some universally agreed upon foundational principles or kind of big rocks, right? We're typically limiting range of motion, especially extension and external rotation, working on controlling pain and swelling, and starting with like some submaximal activation of some of the muscle groups around there, as well as limiting weight bearing, right? Foot flat weight bearing, just to limit hip flexor activation and some of the bony stress or shearing at that proximal femur, right? With those, is there anything in particular you feel like is essential or maybe missed by a lot of rehab professionals?
I think for my experience, it's if people push range of motion too much. So
Okay.
I think, we don't necessarily have flexion limitations. We don't necessarily have rotational limitations. We do have an extension to neutral for about 6 weeks just for the capsule. That's kind of what we are most concerned about is the capsule. But I think the biggest thing is for clinicians who don't see hip arthroscopy or any hip post-op a lot, it's just letting the motion come back on its own. Now, I think there's a point at which you can start doing things like joint mobilizations, but I don't really try to do those within the first, and Keelan, you can jump in here, months, at least a couple months. And I just kind of let the patient tell me what motion is comfortable. And honestly, most times the motion comes back on its own and just not pushing it, especially into internal. I know the surgeon that I work with, he really thinks about like, if I do a hip arthroscopy, I'm really only gaining X amount of internal rotation. So it's, if someone starts at 0, we're not expecting them, if they had a hip arthroscopy, to get to 30 degrees of range of motion, right? Okay. So just really kind of taking them through making sure it's better than what it was pre-op and just gently kind of working through those motions.
Sure.
Yeah, and I would emphasize that too, that it's hip arthroscopy, unlike, you don't see it's very rare, and it is a big concern if you would see it, that you see stiff hips afterwards. You don't see the arthrogryposis you see with take any of your scope conditions of the knee, shoulder. It just doesn't happen as often. If it does, it's a big issue, but it's very rare.
Okay. Awesome. So you both kind of set me up perfectly here to segue into some of the questions that I had, because Ashley, you mentioned flexion. We do see some protocols that limit flexion, which in theory should put some of the anterior soft tissue structures on slack, right? So it shouldn't be as much of an issue that way. So tell me, do you think the flexion precautions are more people being concerned about hip flexor and that anterior hip capsule activation, which might, create, more issues with tendon irritation and anterior hip pain, which for anybody that's ever experienced it as a clinician can be really challenging to get rid of once it flares up, right? Yeah. Or do you think it's more about the concern about creating more stress at some of like the articular structures, especially like that anterior superior labrum area where we see so much of the issues started or so much of the pathology?
So that's what we say, most people won't like flexion past 90. So if it's in the protocol, it's kind of just one of those things that for the first couple of weeks, they're not going to like it anyways. So you're not going to push it anyways. But for us, it's more, the structures, even though they took down the impingement, there's still healing surfaces in there. So we don't really want to bring those two things into contact if they don't need to be in those early stages. So we think less of a flexion limitation, but more of a sitting limitation that we have. So we limit our patients to sitting for 30 to 45 minutes, depending, for the first couple of weeks. Now, again, because in supine, when we're arranging them, they self-limit themselves. But in sitting, sometimes they're like, oh, this is what I should be doing. I should be resting. But when you think about it, that's the same position, right? So we put more of a sitting limitation on it than we do like a flexion limitation.
Okay. Interesting.
Yeah, we used to use the term, we started the survey, we'd say we don't want people going into excessive repetitive flexion. So it's a little different. Like it's not hip precaution or anything like that, but the irritability that you could create with it, I saw probably numerous soft tissues there. And also knowing that not doing it repetitively early on to our experience, has never resulted in a loss of flexion later on too.
Sure. So everything's still raw. So you're just trying to limit that.
Exactly.
Yeah.
Sure. Okay. One question I've always had is, again, different protocols have different thoughts about the amount of external rotation that's acceptable, right? So I wanted to get both of your thoughts, and you just kind of alluded to it a bit, right? But how much external rotation range of motion in that early stage do we think is acceptable? And then my question is always like, how much and when can we progress it? Because there's varied opinions, right? And the reason I bring it up is because I'm always leery. You mentioned it, right? I feel like there's kind of these subgroups of people that develop FAI, right? There's sometimes these, and I don't want to overly generalize, but I feel like there's like the inflexible or less flexible male rotational sport athlete, right? And then sometimes there's these very lax people with maybe anterior hip microinstability, especially, I don't want to, again, overly generalize, but like female dancers or gymnasts or that kind of thing. So tell me, like, what do you think is safe from an external rotation standpoint in your minds? And then when can we really start, when is it okay to start pushing it a little bit? Just to limit that stiffness or that inflexibility.
Yeah, we put 15 degrees on it for, I think, 4 weeks. And then after 6 weeks, it's, by that point, the capsule should be healed. And so then beyond there, it's fine. Now, I think this for me is a little bit case to case, for person to person, really, because if it is a female, I am way more cautious with what positions I'm putting them in after a hip isolated hip arthroscopy, just because females can tolerate so much less instability than male counterparts. So I think if it's a female, I am a little bit less, I'm never really aggressive with motion, but I protect those a little bit more. So I tell them, no, we're not lying in prone. We're not getting into external rotation really above 15 degrees. And I think when you think about function, right, like in order for them to walk, they're going to get into some extension. So functional stuff is fine. But I don't really want them lying in prone, because then generally what they do is come up onto their elbows, right? And then you're in that long, position for a long period of time, and it's the irritability factor. So that's really it's a female to male thing when it gets down to the nitty gritty for me.
Okay.
So, I don't know.
Can I expand a little more? You worry more about them from a stability standpoint, just based on like what factors?
I generally worry about females who, and I don't know, Keelan, you can jump in here, females who have isolated hip arthroscopy. Micro instability is a real thing. Undiagnosed mild dysplasia is a real thing. And so for me, clinically, it's the ones that go really bad after hip arthroscopy are generally females who have some type of borderline or micro instability. So I always just am extra cautious with those patients.
Yeah.
We see, Ashley and I see, we all know the same docs around here, but she definitely sees a lot more of that younger female population than I do concentrate. I see kind of across the span spread out, but, and I don't think we have a consensus, because some of our surgeons, it's procedure dependent, extended repair, was the labrum repaired with it, but
capsule
it's the same
repair,
thing. So see variability there. I've seen anywhere from 15 to 25 degrees. It's become less over the years. I think it used to be like 45 degrees less than that, neutral, and then gradually work your way out to 45 at certain. They don't stage it like that much anymore, at least in my experience. But to me, it often comes down to the same thing Ashley said, whether it's procedure dependent and also predisposition. If they are, someone like me is probably never going to have that much range of motion, regardless to even force their structures. But the population that she works with tends to be a lot more mobile, even unstable, at times.
Yeah. So do you use kind of the opposite leg as a gauge for some of that inherent laxity, or kind of getting a sense of what their tissue quality or collagen composition is to determine that, to customizing that rate of progression?
I mean, you can, but a lot of my patients have bilateral symptoms, so it really depends on what they have going on the other side. So we always say, like, use the other side as your kind of goal, but it's really hard when someone's dysplastic or has a cam on the other side as well, because also that's affected. Honestly, it is just based off of like a body type and their history and some of the things they say subjectively, some of the activities that they do. That's more of where I get it from. I do look at a Biton, but sometimes there's people who come up lower on a Biton scale who have wild hip range of motion, right? It's very excessive hip range of motion. So I put all of that together when I'm kind of thinking that. So
okay.
We also do. Oh, sorry. Go ahead.
No, go ahead.
We now do our lidocaine injections in-house. So the surgeon actually does them under anesthesia. And so it is helping both of us kind of understand. So he will do the injection under anesthesia and take x-rays during different motions, like external or things like that, and see, for people with cams, you can see like, is the femoral, where is it colliding, and how much levering of the femoral head are you getting kind of out of the socket and things like that. So for dysplasia, how much movement they're getting within the socket in different motions. So that's also helpful for those cases where you don't really know, having that information. I'm lucky to have that.
That's what I was just going to ask you. You beat me to it when I almost cut you off. Is like, do your surgeons give you the extent of like how deep their acetabulum is, or how shallow that socket potential for dysplasia, or like the amount of version in that pelvis and that acetabulum? So, okay. that, I mean, I feel like that is extremely useful information to help to get. I don't know, you know, what your feelings are on Craig's test. I know I have a hard time getting a true sense with that of like knowing like, okay, this is the true stopping point, or, you know, what the actual amount of kind of retroversion is. But
version's become much more of a discussion over the last few years. We talk about in the clinical practice guidelines now, and you know, at least in rehab, you know, we started to talk about it more, you know, in relation to these types of issues, and obviously it affects post-operative rehabilitation as well.
Yeah, yeah. I mean, treating. I'm sorry. Go ahead.
No, I think 3D CT scans are really helpful. So everybody who's getting surgery in our center gets a 3D CT scan. And so that is very helpful to understand truly what's happening in terms of version. So
for sure. All right. So let me move to extension a little bit. When you mentioned it a bit, right? When do you feel like for most of these people, again, we are kind of delineating some of the history and presentation already and factoring that in. But when, for the most part, when you feel like it's okay to start pushing extension beyond neutral, because you mentioned, like I said, with walking and so many of these functional activities, you do need to get it back, right? So.
Keelan, you want to take this one?
Yeah, sure. I mean, and again, I think some of this is with the population I see probably, you know, I said people like myself aren't quite as flexible. Even the athletes I see, you know, are probably, whether it's male or female, just not going to be often as lax as the individuals that Ashley sees, except for a subset of them. So I probably get a little more extension earlier, but really when I say that, it's still, you know, the extension to allow them to walk normally and such. I think it's, you know, it's not much different for me, at least in it, you know, working with the surgeons that we overlap with, than the same concerns for rotational in terms of time, right? So, you know, depending on the procedure, if this capsule closure or healing time is appropriate, then it's more, to me, it's more when you are allowed, if it's 4 to 6 weeks, let's say, you know, probably close to 6 at times for more involved procedures, then it's just a gradual reloading of the tissue to allow it to accommodate. Some of that is, you know, obviously to allow motion to come back, but also just irritability more than anything else.
Yeah. Okay. All right. Next question. And this is just one of my personal hangups here. Hip circumduction, right? I mean, I understand the theorized benefits, right? When you're limiting that early motion, right? That circumduction may help to kind of nourish some of that articular cartilage in different parts that we may not be accessing and that kind of thing. When do you think is a good time frame to start to phase hip circumduction out? I admit I have a personal bias because it's one of my least favorite things to do, just because I feel like 4 minutes each direction, my God, like my arms are just like exhausted with it. So is there like a universally agreed time point? Like, is it 2 minutes? Is it 4 minutes of circumduction each direction that has the most efficacy? And when do we, at what time point post-op, or what post-op interval do you start to phase it out typically?
I feel like if you would have asked me this question 6 years ago, my answer would have been very different than what it is now.
Okay.
I do it maybe the first 2 sessions, and then if their motion feels fine to me, like if it's just reasonable, I honestly stopped doing it.
Okay, good.
So
you just made me really happy.
Yeah, I don't know. Keelan was one of my like early still is one of my mentors. So maybe, I learned a lot from him. So I think he has a very similar view on it. I don't know that I've ever seen Keelan circumduct someone's hip for 4 minutes.
Yeah.
But
No,
I don't do that. Again, it's like first 2 sessions is like a feel good. Get them. It's more of a, they're very afraid to move. And once I do it once, it's more of like, okay, we ripped that Band-Aid off, your hip can move and you feel fine with it. I don't really need to do this anymore. So
yeah. Okay.
Yeah, there's some historical context. That's why you see it in every guideline and such. So, I had my early hip exposure through Mark Philippon, who's known as he's at our university for our medical center for a while before going out to Vail. And when he moved out there's a study. He wasn't the head author, but he's obviously one of the authors, and they found that doing circumduction resulted in retrospective looking back and less adhesions of the joints. So everyone takes that when one person does it, and we're all even in the consensus study, we've all kind of come from the similar training. There's 3 or 4 people who have kind of disseminated, under certain surgeons, and so I can tell you exactly where that came from. But I think it's important to note. So I do it, And maybe I'll often teach a caretaker if I feel safe with them at home to do it. But like Ashley said, I'm not doing this for 3-4 weeks, 4 minutes each session.
Right.
So I think when you look at that, the other thing to consider when they did that study, and I don't remember the years, I still cite it, but the procedures have changed over time too, and we just don't see that happen too often. So maybe in a revision, or someone who really did have range of motion issues. But I think to answer your question, we do it, but it's fairly short, and if it's not indicated after a fairly relatively short period of time, I'm just going to say 2 weeks. There's no scientific number behind that. We start weaning off of that because we're already moving towards other, probably more aggressive range of motion activities at that point.
Okay, good. Yeah, you both just.
So you won't get as tired if you think about that.
Yeah, exactly. I read some of these protocols, I'm like 4 minutes each way. Like
I don't know where that number
on the
came
protocol,
from
but
either.
you're not the one actually like holding this person's leg up for 4 minutes. All right. Another kind of early rehab concept is this whole idea of like restoring lumbopelvic control, right? Getting if you want to use core as a buzzword, I don't know how you both feel about that, right? But activating some core stuff and really kind of getting them maybe out of some of that anterior pelvic tilt posture, right? Activating things and reducing, by putting them in that posterior pelvic tilt, reducing some of the stress on anterior hip, right? Or at least some of the joint part of the anterior hip, right? Tell me, because one thing I always struggle with is from a testing standpoint, right? Like determining like, okay, how much anterior pelvic tilt is okay, how much is not okay. And also from a testing standpoint, I feel like there's also no kind of great test for assessing that. So I wanted to get both of your thoughts on that, if I could.
You want to take this? You want me to take it?
I can give you a little background on a lot of those recommendations. And a lot of that comes from and of course, there's always observations you see in lab-based studies versus what you see in real life. But we do know that individuals, if you look at that population as whole, FAIs non-operatively, preoperatively, tend to demonstrate a greater tilt.
For sure.
Related to symptoms too, right? So now we aren't quite as sure if you correct that tilt, is it actually going to make all the symptoms go away? We hope, we even use that in non-operative treatment as a potential premise without direct evidence of that. But and knowing that correlation, we also make the assumption that after surgery, in most cases, unless it's more very involved, you're probably not touching the pelvis from a scope perspective. So that's kind of where that premise comes from. To me, I think I look at it in 3 different kind of buckets. I don't look at standing position, right? Do they just tend to are they inclined to anterior pelvic tilt? Even though some of your best athletes are.
Yes.
I know there's the classic leg lowering test we talk about, and can someone maintain neutral pelvis leg lowering? That's there's utility there that doesn't really test functionally. And then the squatting, and for me, the single leg squat in the sagittal plane observation, as opposed to the step down. And there's some literature out there. Kara Lewis has some literature that she does that pertains to this. But what we see in that sagittal plane with the single leg squat, if we see I'm just going to use a very general term here, early anterior tilt, particularly if it's correlated with symptoms. That to me is something that then we can focus on that. But to your question, we at some point have to have an appropriate progression to maintain let's just call it a stable pelvis. I hate to use anterior posterior because everyone's a little bit, obviously different.
Sure.
But at some point to see if in a single leg position, a squat can at least maintain, a better control. Maybe that's the best way to look at it, whether it's total excursion or just tendency to drop very quickly in the anterior tilt during a squat. But there's a lot of variability there too. And sometimes you have taken clinical context of symptom presentation and just, there are numerous factors there. For many people, we're never going to, we don't really want to just say, hey, you don't want to tilt at all and lock everything down either.
Yeah. Right.
And Ashley, because I know you work with a stable population where this is a pretty interesting topic. So.
Yeah. And I think, looking at it, it can change supine to standing too. Like we look at supine x-rays versus standing x-rays, and sometimes people's tilt is drastically different in supine as it is in standing. So you think like functionally what's happening when they're standing versus when they're supine. But in terms of a progression, I think I always start in what we think about like low demand positions. So what can they do and how can they control it in positions like supine and quadruped and tall kneeling, and then getting them into their higher demand positions like double leg, single leg, and then multi-directional. So when I think about, restoring it is hard because what is normal is very unclear, but
Right.
at least being able to control it, or, have some good core activation in all those positions in a stepwise fashion. I think about it more that way than I do, do they have too much or too little? Can they control what they have? And how do they feel now compared to what they did before? And I'm not usually telling people anterior versus posterior, sort of shooting for neutral pelvis is really, we see a lot of people who come in, especially people who have done rounds of PT and their hip flexors are super flared. They're like, I've been doing a posterior pelvic tilt. They've been just telling me to posterior pelvic tilt the whole time. And they're just using their hip flexors and they're not using their TA. So really encouraging more like neutral pelvis is helpful. And then encouraging that through those different demand of positions. So.
All right. Great. Just to give some context, part of the reason I wanted to personally ask that question is I'm always, Keelan, you alluded to it, right? About some of these, especially like successful athletes tend to default to that posture, right? And I'm always leery of like, if someone has been very successful athletically, I don't want to start tinkering too much with that and affect things from a performance standpoint, unless, like you said, it is becoming where it, that posture, that position consistently provokes their symptoms and limits it. But I don't want to do anything from a standpoint that might negatively impact their performance athletically. So that's part of the reason I asked that.
I think this is a similar conversation with, and completely unrelated to the actual mechanism. You talk about the hamstring injuries and pelvic tilt and sprint, and that's a whole other thing. So they're very highly effective athletes for what they do. And not that I have the answer to that. I don't think anyone does exactly, but they talk about the pelvic influence there, different mechanics, but, with very high level athletes who are at that, who are at their peak, probably the performance, how much do you change? Right.
Right. Yep. And the other factor for me is sometimes like you mentioned, Ashley, like training it and different progressions, right? I can do it, but I feel like the moment 10 weeks of me doing exercises to retrain it, no matter how hard I try, I feel like if somebody's been adopting that same posture for 20 years neurologically, when they put themselves under like high demand or high kind of
they're going to go back to it
situation, they're going to default to it, right? Yeah. So that's where sometimes I'm like, I'm not going to tinker too much with this. Like you said,
we've
I
also looked at like biodynamics. We do some studies in our biodynamics lab, and we've done them more in our dysplastic patients, but we're looking at, does anterior pelvic tilt change when people have a PAO? And so different patient population, but it changes like 1 or 2 degrees, right? It's not a ton. So I don't even know clinically that we could see that. And so I think it's just one of those things where you just have to make sure that their symptoms are controlled, and then getting them stable around, what we think is neutral and what's neutral for them. And that's kind of what I do.
Yeah. Okay. Cool. All right. That makes me feel a little better that I'm not, blatantly like just ignoring things that I should be addressing, because I do address it, but again, under the guise that, like I said, I want to kind of use it more from a symptomatology standpoint as a guide, rather than like trying to make sure everything they do is in a posterior pelvic tilt athletically. So, yeah.
Yeah, and I think too, like the anterior pelvic tilt, if you're monitoring their iliopsoas flexibility and the rectus flexibility, like that, who knows how much that plays into it, but I'm more concerned with restoring that to normal than I am restoring their pelvic tilt to normal. So
sure.
Probably similar to the scapular discussion with shoulder issues, where what is normal? I mean, there's very gross deviations and such, but there's also a big range for what could be considered normal, and you have to correlate to the clinical picture too.
Yeah, absolutely. Yeah, and especially in like a baseball athlete that is primarily unilateral and has all these adaptations. Yeah, sure.
Yeah.
Okay. Next question, and I don't think you got into this in the paper a little bit, but I see more and more post-op hip protocols advocating for BFR. So, and I feel like, again, blood flow restriction is kind of one of the new trendy things in rehab, right? And admittedly, like we use it a lot with our post-op knees. I've seen more and more protocols using it for hip scopes, but I have not seen a ton of literature on the efficacy of using it with post-op hips. So I wanted to first off find out from both of you if there are any studies out there that kind of looked at what the evidence says about using it. And I will also say again that with knees, I feel like I can justify a little more because you're working on things distal to the cuff, right? So from a physiological mechanism standpoint, I can see how things further downstream are impacted. Sometimes with hips, I'm like, well, all the glutes and stuff is proximal to the cuff. So all these things that in theory should be affected are maybe not as impacted when you're working things that are proximal to that level of occlusion. But again, on the flip side, that said, having taken blood flow restriction courses and trying it on myself, man, I mean, like those glutes and hip flexors feel like lead. So I wanted to get the sense from both of you, like, do you integrate it into rehab? What does the evidence say, and how you feel like, it should be implemented or integrated?
I don't personally use it.
Okay.
I don't feel like, I think when I think about knees, and again, I treat mainly hips, but when I used to treat knees, the quad, you would fight the quad in almost everybody. And so I think that that's a really good use for it, right? To kind of work on early quad activation and things like that.
Sure.
I don't find myself fighting activation and strength progression in my patients too much.
Okay.
So I just kind of go with the kind of old school exercises, to be honest. I don't believe that there's anything at the hip, and Keelan, I could be wrong. I haven't looked at this because I don't use it, but I don't believe that there's anything out specifically for hips to use it. I think that the company says that you can use it, right? I think
Of course,
I don't know what
right.
I don't know that there's been any independent studies done on it. I just spend my time, working with my patients on exercises that they can do outside of PT. But that's just the way I do it. I don't think it's right or wrong. And Keelan might do it differently. So.
Okay.
Yeah, I don't use it as my standard of practice. I don't fault people who do because I have no reason to tell them not to.
Right.
I do find, I think this is what Ashley said, I don't have people coming in as weak, to this procedure or afterwards paying the price of the gluteal or any muscle that the quadriceps pay after arthroscopy. So it's more case by case. But I don't have maybe I should. I think we will know the answer to this much more thoroughly in a few years because your question made me think about this. If you look on the NIH website, there is a RTC that's being recruited for now for this. I think Dr. Nope, I believe, up at his group up at Rush is doing this. They're in the recruiting phase, so they're going to look at, if I remember, 6, 9, 12 months, if I remember correctly, after stratifying people to receiving blood flow restriction therapy after arthroscopy and or not having it, right? So I think we'll have a better idea of this, and that's the only study I know of that has. Again, I believe they're only in the recruiting phase.
Okay, got it.
I think the other thing too with hip arthroscopy is when you compare it to ACL rehab, it's so much quicker. Patients are running our patients run at 3 months, whereas with ACL, it's 6 months minimum, right? People are running. And so I don't feel like I need to fill the time that much. I think that, you kind of just are so quickly back into sport. I don't really know how much faster we could do it. Someone could argue that maybe you could have these people running in 8 weeks. But, I think that there's detriment to that as well. So I think it's a pretty quick recovery. People are doing things within a reasonable amount of time. So for me, like the bells and whistles aren't important here, but they are for knees, right? Because it's such a long period of time. People get bored in those early phases. You need something else to do to keep it interesting. I just think for hip scopes, it's just fast. So.
Yeah. Okay. All right. So I don't want to spend all day going over the early post. I did want to kind of touch on some of the other phases, time points that the paper went over. So in the intermediate post-op stage, I wanted to find out from both of you, and this is, I'm sure this is a loaded question, and I don't want to put you on the spot. I'm sure, again, it's very case dependent, like we mentioned, and varies based on what was done and that kind of thing. But in general, at what time point do you feel like it's okay to begin really, instead of your basic kind of sub-maximal stuff, when do you feel like it's okay to really begin with more aggressive hip flexor activation? And what do you feel like, is there kind of a standard progression or way that you introduce it or sequence it? I'll ask that.
Yeah, I think one of my least favorite things to fight is the hip flexor. So I do everything in my power to not have to fight that. for both myself and the patient. So I usually start somewhere around 8 to 12 weeks, sometimes pushing it to 12 weeks.
Okay.
I start in, very low level position, short lever. Sometimes I never go long lever. Like if patients aren't kicking or dancing and they're like happy and having a successful rehab, I'm not going to sit there and do a ton of long lever hip flexion. The thing that I care about a lot is that they can, I think for me, when I see people who have, these hypertonic hip flexors or whatnot, it's because they don't know how to use their core. So they're really relying on their hip flexors. So I think that I care more that they can use their core and demonstrate like supine marching or like, 90-90 touches and then some easy things in standing. I'm not gonna really poke the bear too much, but unless it's like a soccer player or a dancer, and then we have to do those things. And it's very slow progression of short lever, in supine, and then getting them into standing, doing short lever isometrics, a little bit of long lever isometrics, things like that. So I don't know, Keelan, what do you think?
Yeah, and I'm pretty similar, and even if I'm a little faster at times, that's just the population I work with. But that hip flexor, and I have to, you have to explain that to the patients why you might be. I guess you'd say it's kind of a stratified approach where we much more early and, for lack of a better term, aggressive rehabilitation, posterolateral muscles, gluteal muscles, etc. Protecting that hip flexor. Then you get to a certain point though where the functional progression is going to use hip flexor based activities, and then you have to. You do have to carefully monitor, but also, it might be the limitation to your rehab progression at some point based on symptoms and such. And you do have to explain that to patients, or if you're getting to the point where they're not just rehabbing you, maybe they are starting to work somewhat with their team, their strength coach, et cetera. And Ashley had mentioned, I unless it's case dependent, like if I get to my dance just with when we say long lever, like straight leg raises, I might never use a straight leg raise in my rehab. Yeah. I can do resisted short lever hip flexion through a functional range starting an extension. There's a bunch of different activities out for that, and actually add external progression before I can do a straight leg raise, and probably be much less of a risk of creating irritability, which is just going to limit your rehab once it happens, as I think you were saying.
Yes. Yeah. It's horrible to try to get it to calm down once it's flared up, right? Yeah.
And it sends patients into a little bit of a mental spiral too, because it's in such a similar location as their pre-op pain. So yeah, I think I agree with Keelan, like moving through like, functional positions like planking with, bringing knee to chest and things like that, or doing some lunges where you're incorporating like a step up, and you can do those things. And I feel very fine doing those and comfortable doing those without having to use long lever straight leg raise.
Yeah.
Yeah.
Do you feel like if, again, I don't want to get too simplistic in saying that like rectus femoris does all your long lever stuff, or iliopsoas does all your short lever stuff, but do you feel like preferentially one gets weaker than the other, or do you feel like it's pretty similar, just kind of lumping all of them under hip flexors? They all tend to get a little weaker just because of that limiting them, or some of the effects you get just with disuse.
I don't know, Ash, I think I've never looked at that specifically, right? But my
that's
assumption
what I mean. I don't
has
want to
been
be overly simplistic.
It's probably the psoas because of its proximity to the hip joint, and even if you're not releasing it, which you don't do as often these days, it's just a general, right? I've always assumed that. I've never tried to actually delineate that. It's been based on assumption or anything else.
Okay.
Yeah, me too.
Okay. All right. So the paper mentions there's typically like a lag in some cases, right, in restoration of hip strength, and in some cases like persistent weakness up to 1 year post-op. I just want to get a little nerdy and sciencey for a minute, if we can. What do you feel like are some of the potential contributors to that issue? Do you feel like there's some sort of neural inhibition related to pain? Do you attribute it to just altered or compensatory loading strategies or mechanics? I ask because, again, I know there's some people that float this idea of like glute amnesia, which I don't know that that's necessarily a thing, but I do know, again, that a lot of these patients tend to demonstrate weakness in a lot of the same muscle groups when you get some of that articular, or FAI type of symptoms, right? So what do you feel like are the contributors at kind of like a neurological science level? What causes it, or how does it manifest?
So for pre-op, I think it's pain.
Okay.
I think that pain is just, it's sometimes these patients can't maintain a good functional status. So then these muscles are just going to get weaker. And then obviously neuromuscular control is going to be affected and things like that. Post-op, I think that it's sometimes just unwinding what was done pre-op, is that they've had this, long time. If you look at, how for the most part, these patients have been in pain for quite some time. It's, at least for my patient population, it's very rare that they've, been diagnosed and had a hip scope within a somewhat reasonable amount of time. They've been kind of passed around, and then before they get anything. So we're fighting like years of, just them not being able to exercise or maintain appropriate level of function. And I just think that some of it is undoing that years of, figuring out what was wrong and then what do we do about it.
Sure.
So maybe not so sciencey is what, but I do think it's that, so.
Okay.
We don't even know preoperatively exactly what, all the mechanisms either, except we know people who are weaker are often the ones who are more symptomatic, morphology kept the same, and some we don't know. Postoperatively is interesting because, right, it could be all of the above, which is a terrible answer, I know, but it could be any or all of the above. And also sometimes just includes, we have to be honest, the quality of rehab they had afterwards as well.
Yeah.
Maybe being released,
the other thing I was going to say,
and still being weak, because we know not everyone's objectively testing. Part of that may be because we're not even 100% sure what to objectively test, but we know from a strength perspective, particularly in athletes, a lot of those people are probably not getting the best objective testing to know if they were, where they're at when releasing them. We're probably just using symptoms as the guide, if we're being honest, in many of those cases. Not we, but just being very general there, but we know that happens not just with hip arthroscopy, but just across the board.
Okay.
Yeah, I think that patients who don't see hips all the time, when people get symptomatic, they really tend to just stop instead of, finding things that are reasonable to do that can get them stronger. Because I think that sometimes the pain comes from weakness. And so generally when I'm seeing someone in a kind of our triage clinic setting that's not doing as well, it's just because they have persistent weakness. And then if you can encourage them to work through some of the pain. There's some things that I red flag, right? But for the most part, if you just encourage them to work through some of those symptoms and then their strength kicks in, then you'll find their symptoms start to decrease. And so I agree with Keelan that sometimes it's under rehabbed is a big thing, I think.
Yeah. Okay. And do you feel like some of that weakness just contributes to kind of like this muscular imbalance at the joint or that kind of thing, just putting more stress on certain tissue structures or that kind of thing?
Yeah, like weak glutes, really making the hip flexor be hypertonic and like the T-band be hypertonic. And those are the biggest, and I think too, it's a mental thing, right? Because that's where their pre-op pain was. So then now they have a couple weeks of pain, they're, shut down, and then those muscles just kind of become their prime movers when they don't really need to be. So,
yeah. Okay. So on that, just to expand on that a little bit, I'll pose it to both of you. Do you feel, and this doesn't have to be, you can say like, no, I don't really feel like that. I'll give you the option to pass on it. But do you feel like there's one muscle group in particular that seems to be more impacted across the board post-operatively in this group? Or do you feel like it's just very individually specific and kind of global?
I think it could be global. Global might be one. I think depending where, if you're speaking to strength, right? I think that could be fairly global.
Yeah.
I think functionally the impacts, probably from the gluteal muscles, which we say for everything, and the rotators are probably, rotational strength is probably at least in the past, has been underappreciated.
Okay.
Pain, if you're talking about pain specifically, it's the hip flexor that I would go to most of the time.
Sure. Yeah. No, I was focusing more on from a strength standpoint, but yeah, you're right. I hadn't even thought of it just from the pain standpoint, the aspect of it.
Yeah, I mean, glutes and rotators. I would say glutes and rotators for sure.
Okay.
So.
All right. So just to expand on that, since obviously both of those have a significant functional role in weight bearing, right? I wanted to get more into kind of the motor control aspect of things. So I know there have been a ton of studies looking at altered mechanics, particularly like with squatting, right? And step downs, those kind of things, right? So I wanted to ask, what do you feel like in this population, especially post-operatively, Is there a movement plane that you really focus on that tends to be kind of most impacted or altered that you really try to target and devote time and energy to with the post-op process? Or is it all just based on, I mean, obviously, again, we're all doing an individually specific assessment and that kind of thing, but I guess I'll say, is there a more recurrent pathology in a certain plane that you tend to see?
I know I've harped on it for, and a part of this just, I think, so what we've tended to focus on rehab is, the rotational component. But when I say that, I think part of that, it is important. And part of this, the labrum has a rotational, some rotational stability as far as one of the roles of the labrum, et cetera. So it's compromised. But also, I think in rehab, again, I'll say we as in like just being somewhat general, is that we often tend to sell short what you need to do to get rotational strength back. At some point, you need the pelvis rotating on a single on a singular femur, right? And creating motion from, I guess you'd say, the bottom up and stabilizing the femur, rotating the pelvis, strengthening in that transverse plane of motion, creating endurance while not allowing the pelvis to drop in the frontal plane. There's a lot that goes on there, and I think a structure progression sometimes doesn't get pulled into rehab, or it isn't fully played out, to the point for, especially for athletes who have those rotational and repetitive rotational demands.
Yeah, I think that's one of the things. Oh, sorry, go ahead.
No, good. Go ahead.
Go ahead. I think that's one of the things that Keelan taught me very early on was, rotating pelvis over a static femur, and using that to strengthen is really a game changer. And so I think that can't be overlooked.
So if I just want to clarify with both of you kind of conceptually, would you, just to say, so doing clamshells on the table is not necessarily going to translate into what happens when you put them in kind of a closed chain functional weight bearing position. Is that fair to say? Like, are you doing a lot of kind of rotational training and that kind of thing in a single leg weight bearing position?
Yeah, and I think that there's a place for both, right? And so I think that for me, with the way that I tend to structure it is that very early on for hip arthroscopy, patients' home exercises are their table basic strengthening exercises, basic endurance exercises. And then when they're in the clinic, I'm lucky enough that I get an hour with them one-on-one. It is maybe a quick table warm up, but 45 minutes of that is single leg strengthening. And so whether that be, just a single leg balance off of a step, or, the kind of the weight bearing rotational stuff that we've talked about, standing clamshells, some of, things, RDLs, working with some rotation. It's 45 minutes for them when they're in the clinic with me of single leg standing exercises. The top down, bottom up stuff, right? Adding bands to the lower extremity, adding bands where they're using their core, is really very beneficial for these patients.
Okay, good. That's I was just going to ask for some specific examples. You've already segued into that, so that's great. Okay.
I mean, for clinicians, I was kind of, it's once we get them into that position, yes, we're starting with double leg, let's just say squat, any type of activity, 30-second single limb stance. If they can't do that, then we probably don't want to jump the gun if they're collapsing in the frontal plane. And I do see that as well, because with good intention. So I think it's structured, having milestones that they have to consistently hit for both to be progressive, but yet monitoring that you're not jumping the gun too much when they just aren't there yet.
Yeah. So from like a competency based standpoint or checklist, what are some of the milestones you want to see, Keelan, before you progress them?
We look at, and again, that it's universally agreed upon. One, I always look to see if they can just tolerate their home program well, which is all the things Ashley had mentioned, and you hope so, right? You expect that. Then walking, right? For in just daily walking, regular activity. At that point, then there's a bit of a load progression. Bipedal activities, which are much less. There's much less joint reaction forces. I always have to explain to people, it's not like this. It's like this when you go to one leg in terms of your joint reaction forces. Do they tolerate the 2 to 1 leg progression? Well, that's a time when they are vulnerable. Let's put it that way. They tolerate that well. Then we start singular plane movement on one leg, multi-planar movement. And anytime you move in one direction on one leg, you have to stabilize in the other planes, right? Resistance, speed, opening up the range, and so, that's the progression that I look at. It might be single leg stance, single leg step down, single leg squat. Then, as Ashley mentioned, then going to the activities that involve rotation on the single leg, in the single leg position, etc.
Got it. Okay. Perfect.
Yeah, and I think sometimes it's hard to get someone from double to single leg, and I think that sometimes people just think that that's the only way to do it, is once they're in double, they're single. But there's a lot of baby steps that you could take in the middle there, like staggering them or offloading one on a yoga block, right. Split stance, putting one foot on a ball, right, to kind of get them to offload a little bit more. And I have found that to be very helpful. If someone's struggling, they look great in double leg, but they look not so great in single leg, how do we get them there? And there's a lot of ways to do that I think sometimes are overlooked.
Awesome. Yeah. Just from a practical standpoint, I wanted to pose it to both of you, just especially for the clinicians who may be on the hook as far as documentation and that kind of thing that are listeners here. Do you have a kind of preferred outcome measure that you use? Do you have one favorite? Is it hip outcome score? Is it a Harris hip score? Or is it LEF? I'll just to throw that out there. Is there one that you kind of both have adopted, or is it kind of specific to population?
Ash, go ahead and answer. I have an answer that is completely company dependent. So
yeah, okay, fair enough. Yeah,
I'll let
I mean, the surgeon I work with also is a part of Anchor. So but I think that even before he was in Anchor, we use the IHOT. We use the UCLA activities score scale, whatever that one is, score.
Okay.
We use a kinesiophobia scale. And those are the three things that we use regularly on our patients.
The kinesiophobia scale, are you talking Tampa scale, or is there one? Okay.
The Tampa scale, yeah.
Yep.
We've talked too about, we behind the scenes talk a little bit about grit. And so, you kind of have this feeling when someone's going to do really well post-op, and a feeling when someone's not going to do really well post-op.
For sure, yes.
But there are a couple scores out there that will actually measure that in a resilience scale. We've talked about adding that, but in terms of hip function, we are lucky that someone created the ability to do the IHOT on the iPad for us. We use the IHOT for hip function.
Gotcha.
And there's a number of validated scales, the IHOT obviously being one that has probably received the most. I happen to, and Ashley's doing her PhD with Rob Martin, who developed the hip outcome score. So that is our Epic integration, tablet integration right now. And it's a great outcome score, but there's a reason why we are also we don't have others unless we do it, manually. And that is, part of our, that's our IT integration right now, which how slow in a big system those changes are made. So not that I'm against it. I think there are other great outcome scores, but that's where we're at right now, and part of it's for that reason.
Sure.
Okay. The IHOP is hard to do on paper, measuring and doing all the calculating for it. It's cumbersome. So I get if people don't. We're very lucky that it's just kind of built in for us. So.
Seamless, yeah. Some value in AI and tech, right? Yes.
Yeah.
I don't want to keep both of you too long, but I did want to kind of delve into some of the late stage stuff too. So tell me, if you can, what are your kind of go-to, what do you feel like are the essential return to sports tests? Because I know, again, in ACL, we've kind of gone ad nauseum about what are the best return to sports testing, what are the gold standards, that kind of thing. But I feel like in hip, maybe there's somewhat less well established, or there's the gold standard might not be as universally agreed upon. So I wanted to find out from both of you, what are some of your go-to must-haves as far as testing?
Yeah, we're actually working on putting, it might be actually the exact same group that did this paper, is working on return to sport after hip injury, because all of us kind of believe that once patients get to more of a sport-specific progression, the sport-specific progression looks the same despite the surgical procedure. Now, the timings may be off, right? Things like that, but the progression itself is the same. And so we're putting that together in terms of, I think there's some, Keelan and I were talking about this the other day, some people start plyometrics first, some people start running first. So kind of planning to kind of cover, what that looks like for, from our minds. But for me, I look at dynamic planks. I look at some hop tests with rotation. I look at their ability to kind of decelerate is something that I've been using a lot more. So how quickly can they accelerate and decelerate, and what does that look like? I don't use a ton of the hop tests. I know that some of the ACL ones, and I think they're starting to kind of pare them down now, had like 6 or 8 hop tests. I don't do all of that, if I'm being honest. I pick a couple hop tests. I pick some deceleration things. I pick some sport specific activities, some high level planks, and see how their control looks for their core. And if I'm satisfied there, then I feel pretty comfortable.
Okay. For your, can I just pare it down a little more, Ashley, for your deceleration testing, how are you going about that? How are you
like
examining
sprinting,
or assessing that?
Seeing how quickly, like if we're doing like, 10 meters, 10 meters, right? Acceleration, deceleration, or acceleration, sprinting, deceleration, like what does it look like? Can they do it in a reasonable amount of time? There are some norms published out there that I'm starting to kind of integrate. But how quickly can they do that? And when they're decelerating, what do they look like when they decelerate, right? Do they have do they have good control? So the time component is something I'm trying to incorporate. And I think the folks down in Nashville are looking at that. But I really just look at, can they do it and what does their control look like? And then can they do it within a reasonable time frame? How like lengthwise, right? Does it take them, 50 meters? Now we don't have that in our clinic, but if they can't decelerate within a reasonable time frame, then that's a problem to me. So
are you typically like videoing them and you have like a fixed distance that you assess them over?
We have a long hallway. And so I have like tape on the wall in the hallway where we kind of do it. So
okay. And it typically, like when you have them decelerate, are they just coming to a complete stop? Are they doing change of direction stuff?
You can do both. Yeah, you can do. I think both are reasonable. And I think some of that gets into like the more sport specific movements. What do they need? But I think change of direction is always great, but you can also do it just in a straight plane. So
okay, got it.
Yeah, and I'm very similar to Ashley because there really isn't anything validated out there.
Yeah, there's not the others.
Well, that's what I was wondering.
I have we borrowed off our ACL test and then we pared down. There's a little bit of evidence for the medial hop and such, but not a ton. You'll hear of the Vail return to sport test, which they use, which the reliability I think is validated very well. But they have the same challenges that we have. That's not a good or bad. It's just kind of where we stand for all. And return to sport testing is already challenging. I do think it's important to delineate kind of return to train versus return to sport. So I look at it as their entry level to return to training to prepare for return to sport, as opposed to just blanketly say, you're good to return to sport.
Yeah.
We have the advantage, and maybe disadvantage, because then we have to figure out exactly what we have force plates now that we're looking at, and we have a few kind of small scale things we're looking at there. Because there's not much out there on that. There's nothing out there for that for hip arthroscopy, but you can get some interesting metrics. Now, how those are going to apply, other than saying you either before, after, or you're asymmetrical, we don't know that yet. But you can get some granular data once we filter that out and figure out what to do with it, we meaning just in general, because it probably won't be me, then I think there may be more utility. You could say more to guide you, but I do use it. I wish I could give you better guidance on it, but I don't think anyone really can at this point.
No, I hear you. Yeah. So just to expand on that a little bit with the force plate stuff, are you doing like a counter movement jump? Are you doing more single leg stuff? And if you could maybe just, I don't want to tend, because I'm sure this could go in a very lengthy tangential direction. So I'll ask, what type of differences do you typically see with the force plate in terms of the loading strategy? What are you noticing, I guess?
I wish I could tell you I'm seeing something, because it would help me kind of figure out what we want to, in terms of something fairly generalizable. I don't think what I'm seeing personally, for the short amount of time I've been using it, counter movement jumps always utilize, and the single leg test I do tend to emphasize a bit more single leg jump, squat jump. Sure. I think we do see that there you can get some deceleration information, in the impulse information, and we do see asymmetries there, both non-operatively and post-operatively. And one of my more recent interests, though, I just have to figure out a way to get more information, because the numbers aren't high. I'm looking based on what we saw, what has been noted with the medial hop jumps, looking at the hop and return test, which is that left to right jump. In time to stabilization, and then the quality there. I think there might be something there, and I hope we're doing a retrospective chart review of that. But I don't have any information to share on it right now. I'm hoping to see something there, because then maybe it will be a more useful metric specific to this population, because we're taking the same approach we do with other lower extremity injuries right now with it.
Sure. Right. Yeah. It's just not quite as.
Oh, sorry. Go ahead. Return to contact. progression is really great. So I think that sometimes
right.
people forget about, they say that they're cleared, but what does that actually look like? Because they're cleared from our standpoint, but they've done no contact, right? So football, soccer, lacrosse, anything like that. We
Yes.
focus a lot on like half field with like one or two individuals who are not necessarily, they're more just like barriers, and then getting into full field where you're playing and increasing time and increasing amount of people that are on the field, and then increasing like intensity, like what level of contact are you having across those shorter kind of distances, and then increasing it, and then increasing time of play. So we use a return to contact progression as well, which sometimes happens after we release them.
Okay. Yeah. I mean, I think that's crucial, right? Matt Taberner, I know, has done a ton of articles now on his like controlled chaos continuum, right?
Yeah.
And more and more, I think it's coming out on how important it is, just because, like you said, I mean, some of the stresses we expose them to in rehab just can't replicate or simulate what's going to happen in the game
unpredictability of a full field with like the turf or grass or whatever they're playing on underneath them, weather conditions. So we're big onto that.
Yeah, awesome. So Keelan, you kind of set me up perfectly for my next question to both of you. Just again, because I know we both have to wrap up here and everybody's got to work. So tell me, in terms of some of the literature out there and some of the research that's ongoing, what do you feel like are some of the gaps in the evidence for hip arthroscopy rehab currently? And what would you personally like to see studied or explored a bit further?
Yeah, I think, and this is just really just dovetailing off what we were just discussing, the predictors of success and there's some of this is known to some degree, but as defined by a full return to sport, right? Not just returning, but a quality of return to sport, to play. We do know like the factors that seem to like, some individual factors. Maybe the better way to say that is the rehab factors that influence that. We know some of the patient-specific factors. We know it takes longer than people might say. We know that people return to sport, but return to sport, if you define it by full return, the rates are lower. All that's out there. But what can we do in rehab that affects that? Because that also it justifies being in rehab, and being in rehab maybe longer than some people typically are. If you're outside the environment where pros, high-level college, once you get to your other athletes, insurance cuts us off sometimes. We have to justify how long we might keep those people there. We don't have all that yet, but I think that would be, one, clinically useful, but also useful just, from other perspectives as well.
For sure. Like a rehab prognostication standpoint.
Yeah.
And, visit utilization. Sure. Yeah, absolutely.
And if it gave you the 3 or 4 things as opposed to maybe the 10 things we're working on that you should emphasize, it also would just kind of make it more precision care, I guess is the way I'm looking at it.
Yes. Yeah.
Yeah. And I think
Ashley, you have any thoughts?
Yeah, I think that hips are like, if you tear your ACL and you're an athlete, you're getting your ACL repaired, right? Or reconstructed. Sure. So, but with hips, it's like, there's so much more. People go like periods of time that are non-operative, and then like for whatever reason they're like, I'm going to do it now, whether it's I want to get through my senior year, I want to do something. There's not that like immediate need to do it, and so I think that it's a bit more challenging to understand like who actually needs it, right? Like there's so many people walking around with FAI, like who are the true people who need it, and who are the people that we can say, hey, you can wait to do this until you're done with college sports as long as you're fine, right? So I think understanding some of that, because again, it's not something that needs to be done immediately. So, and I don't think, at least in our practice, it's never the first line of defense for someone coming in. So.
Okay. Perfect. I mean, I could keep you both another hour talking about the injury prevention side of things, right? And how it develops and why a huge percentage of people have it but are asymptomatic, right? But
all your hockey players up there.
Yeah, exactly, right? Yeah. So, but that would go on way too long, right? So I wanted to give you both also a chance to kind of elaborate or plug what kind of projects do each of you have going on here in 2026, or what are some of your interests or projects that are happening right now?
So we just finished up a study that's defining the psychometric properties of the IHOT-12 in individuals with hip dysplasia, so undergoing conservative management. So that's one thing that hopefully will come out at some point this year. We're also looking at the, does physical therapy, have any benefit for individuals with hip dysplasia in changing their neuromuscular control? So looking at, before an 8 to 10 week course of therapy, looking at things like strength and single leg squat performance, and then redoing those metrics 8 to 10 weeks later, putting it together with their symptom pattern and seeing kind of if we can find some factors that, indicate success or failure with conservative management, especially in that mild to moderate group with hip dysplasia, which is a little bit of a gray area. Some people would say you can do hip arthroscopy. Some people would say you should never do a hip scope on these people. So just starting to define that a little bit. Working on those return to sport consensus with Keelan is one.
Oh, cool. Okay.
Yeah, so those are my 3
awesome
big things.
Without kind of putting you on the spot, are you able to give a sneak preview without violating like any editorial rights? Or,
yeah, I mean, I think that I don't know,
property?
Keelan. Yeah, I think it's fine. So I think one of the things I'm really spending a lot of time on is working on some type of like visually appealing table, right? Because I think, and Keelan and I were talking about this behind the scenes, getting a little bit, we won't have the answer to it, but clarity on who does plyos first, who does running first, and why both of those things are done. So that's one question that we're hoping to answer. And then providing domains. So like return to running would be one domain. And then how do you progress through that? And then plyometrics is one domain. And then how do you progress through that? Sure. Things like accelerating, decelerating, how do you progress through that? And then where do they fall in terms of relation to one another? So that it kind of, because, one thing when we were talking about this, where these don't operate independently, right? You can be doing plyometrics while working on change of direction. So how do those things overlap, and what stage do you need to get to in plyometrics before you go to the next phase, and then what high level plyometrics can you be working on while you're working on kind of the next domain? So kind of working on those types of things, but it is going to encompass all hip injuries. So and we say hip injury more meaning the non-arthritic population. So because again, we do believe that once you get to a certain point, the progression is all the same. So
right. Yeah. So, but it sounds like you're doing some really interesting stuff as far as maybe more fully developing or fleshing out that criteria-based approach. So that's awesome.
Yeah.
Cool. Keelan, how about you?
Along with the things that Ashley had mentioned, which for our ISHA group, we have a big group that works there. She gets tasked with writing it more than anyone else. So it's a lot of work for her.
She was lead author. I wanted to make sure you got full credit for that. Yeah.
Then my other tasks kind of within the hip related, at least clinical practice guidelines, which we just released the arthritic one, and then I think we are in the early stages. We just kind of author discussion, and I'm not the head on this either, but we'll be part of it. Actually, I don't know if you are either. I can't remember, to be honest. The greater trochanteric pain.
I got roped into this. I'm on that.
Yeah. So that's that will be a first, though. I mean, that's not been most of ours are revisions at this point, so that would be nice to get something out there regarding. I couldn't tell you it hasn't been started yet, other than getting authors willing to contribute because it's a lot of work. So those are the kind of two bigger, as far as anything publication wise and such, probably what I would be more involved in, and then just continue more teaching, a little traveling for that as well.
Right. Cool. And are you still involved with the hip SIG with the ASBT, Keelan?
I'm rotated off the chair there now.
Gotcha.
So
all right, good.
So Steve Clark up in Boston is the chair, and who's with Northeastern, and then Phil Sheedy is now down in Texas is the vice chair. So I'm always willing to contribute, but I am not tasked with the other responsibilities that they now have.
Right. Yeah. Well,
I'll go to the business
like
meeting at CSM.
Too much, so we'll let you know. Yeah, right. Awesome. Well, this has been great having you both on. Like I said, I could keep you both for hours here chopping up more hip stuff and picking your brains, but I would be welcome to having you both on again to kind of coming at it from another slant. But I know you both are very busy, and I appreciate you taking the time to come on. So thank you.
Anytime. Thanks for having us.
All right, great. Thank you both. Have a great day. Good luck with all the snow in Pittsburgh, and and hopefully things will be back to normal soon, right? Spring,
hopefully
not too far. Right?
Yeah. All right. Thanks.
All right. Take care, both of you.
See you guys.